Good morning, everyone, and thank you for joining us for The Way Home, a virtual summit on homelessness, serious mental illness, and substance use disorders. My name is Kristen King, and I am the lead virtual event producer for this summit, so you'll hear my voice in the plenaries and also several of our breakout sessions. Before we begin, we have a few quick housekeeping items to go over with you. And this first session is our opening plenary, Connecting the Dots, Health, Serious Mental Illness, Substance Use Disorders, and Housing. I do want to let you know that this event is being recorded. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. At this time, I'm going to open up the line for our moderator, Marty Fleetwood, and I'm going to turn it over to Marty to kick it off for us. Marty, take it away when you're ready.
Hello, all you handsome and beautiful people. Hope you're having a great morning in America. The Way Home, which is what we are now commencing, is a two-day virtual summit on homelessness, serious mental illness, and substance use disorders that SAMHSA is hosting through its Homeless and Housing Resource Network. Now, this is a very interesting moment because decades ago, in the early 80s, when the research on homelessness was just getting started from the modern era, it really focused on alcohol and drug use and mental illness. So it was the Department of Health and Human Services resources that were funding the inquiry into what was happening and who were the people who were becoming homeless. From that early start and that early foundation, a lot of papers were written and conversations were had, and there was finally a point that enough information had developed on additional populations and additional causes to start gathering. We actually gathered in real time. 800, 1,000 people came to conferences in Arizona, in Washington, D.C. that were sponsored to disseminate knowledge and give people the opportunity to share what they were experiencing, what they were learning, and what they were interested in knowing more about. So we are like leaping into this modern era where we are today into using technology. It's not just technology that has progressed to the point that we can have our convening in a virtual environment. It's also the knowledge we have to share with you. It's amazing how much has been learned, how much experience has been gained, how much we have come up with new ways to get this work done and ways that are making an impact and creating outcomes that are significant. So this summit has been organized into 3 tracks. There's the facilitating access track, how to make sure that people get into prevention, treatment, and homeless services and housing. There's the intervening early track, which is not just prevention, it's also diagnostic and figuring out how early in the life spectrum we can capture and identify problems and get people into care, and then improving services for those who have serious mental illness or other substance use disorders. There's 6 sessions today across the 3 tracks. There's 6 sessions tomorrow across the 3 tracks. So this is really like a voila moment. There's a lot to know, a lot to share, and we're using a new form of technology to get us there. So I'm so glad you're participating, and I'm going to introduce Anita Everett, who's the director of the Center for Mental Health Services at SAMHSA, the sponsor of this event. Dr. Everett, I want to say first for those of you managing the technology, you've been sent by Kristen a plenary program, and it includes the bios for all the presenters for the session. So in addition to having this Adobe Connect screen to look at, you have a separate document where you can actually find everyone's bios. So in that separate document, you'll find a full description of Dr. Everett's bio. What you would learn is the amazing things she has done. She has been on the faculty of Johns Hopkins School of Medicine and the Bloomberg School of Public Health. She's directed 22 community psychiatry programs, so she has covered the spectrum of population needs in doing that work. She's been involved with the leadership of health system behavioral health integration into accountable care structures. So she's right there at the point of intersection of a number of the issues that those of us working to respond to homelessness are involved in. Before she started that work, she also worked in the state of Virginia, where she completed more than 80 inspections of institutions operated and licensed to provide mental health services. So she's been on the ground inside the programs, seeing how things work, but doing it from a system level. So there are many other amazing things to know about Dr. Everett. I urge you to look at the bios in full, but now I'm going to turn over the mic to Dr. Everett to please welcome us.
Thank you very much for that recognition. Thank you very much. On behalf of our Assistant Secretary for Mental Health and Substance Use, Dr. Eleanor McCants Katz, and on behalf of everyone at SAMHSA, including my center, the Center for Mental Health Services, I'd like to thank you for participating in this important event. The work you're doing is helping to improve treatment services, peer support, and other recovery support services and linkages to sustainable permanent housing for people experiencing homelessness. You are making these services accessible, effective, comprehensive, coordinated, integrated, and evidence-based. And you are saving lives in the process. For that, we thank you, no matter where you work in the system. SAMHSA has a long-standing commitment to addressing mental and substance use disorders among people experiencing homelessness. In fact, the PATH program, which was created by the Stuart B. McKinney Homeless Assistance Amendments Act of 1990, was part of the first major federal response to homelessness. Each year, PATH grants to states and territories enable providers to community-based mental health services to provide those services to more than 50,000 individuals with serious mental illness or co-occurring disorders. For years, SAMHSA has also offered discretionary grants for linking people experiencing homelessness to needed treatment and services for serious mental illness, substance use disorder, and co-occurring disorders. Evaluations have shown that the grants are helping people abstain from substance use, find permanent housing, secure employment, and enter into lives of recovery, lives of meaning for themselves that they, without that, would not have been able to attain. The negative impact of mental health and substance use disorders on our communities is perhaps never more evident than when we look at homeless statistics. But together we are working. You and all of us together are really making significant progress in this realm. We're ending chronic homelessness. We're working to ensure veterans, families, sadly, the need for youth and families, housing and homeless services for youth and family members, families is on the rise, and adults have access to the services that they need and assistance with finding a home. I hope the information that you receive over the next 2 days will be useful to you because the work you're doing is absolutely critical. I've personally reviewed many of the presentations in advance, and I know that they've been put together really well. I want to go ahead and thank the meeting planners for this. It has a wide range of opportunities to learn across the different tracks that have been created as a way to organize the information. All of us who work and have been involved with the lives of individuals who are homeless have a humanitarian, we're driven by humanitarian wishes to do best for fellow mankind. Many of us also have opportunities to be in roles where we're stewards of public funds, local, state, and government public funds. And what I'm particularly delighted about, as was referenced earlier, we're emerging with what I like to think of as evidence-based policy, or sort of the foundations for evidence-based policy. And so the concept that we can demonstrate now, and there's several talks that speak to this, demonstrate the good investment that it is to invest in programs like permanent supported housing, that it turns out to be a very good investment of public dollars. And so I think that growing that evidence base so we can have better evidence-based or evidence-informed policy is very important. One other quick thing I want to encourage you to do is to please pay attention to and give us evaluations. Of course, as the meeting goes on, we'll be tracking the comments that we have, but give us your thoughts about this meeting at the end. To be honest, this is a style of meeting that we're figuring out here at SAMHSA. As a person who's run community mental health services, I know that it can be very hard to send staff to meetings, and there's pros and cons of having virtual meetings like this. So we're very interested in how this worked for you as a way to exchange information. On the good side, of course, you don't have the travel and the time lost that's involved in sending staff to these meetings or sending people. On the downside, of course, you lose the opportunity to interact with people from all over the country that are doing similar services. And so we'd like to know the pros and cons as you think about it and participate in this experience. Please fill out the evaluations at the end of the meeting. Those are sort of my opening comments. I'm really grateful for the opportunity to welcome everybody. I can't tell you how over the top excited we are that so many people have signed up for our conference, and we genuinely hope that it's very valuable for you and adds to the work that you do. Again, the sort of humanitarian work that all of us are interested in supporting. Thank you very much.
Thank you, Dr. Everett. So as we turn to our panel, I want to encourage all you multitaskers out there to consider the 3 things we're aiming at in this summit and to help you understand how we need your help in this conversation. So we've already mentioned that you have available the entire plenary program that includes everybody's bios so that you can follow along with both where you are in a session and what other sessions are happening at the same time, and you can follow along with who the presenters are in the various sessions. Dr. Everett mentioned making sure you evaluate the event so that we can hear both how the format worked for you as well as the content. Now the next thing is actually content related. So on this slide you'll see that we are aiming to connect the dots across different areas of responding to homelessness. But the first thing we want to think about is what's the state of homelessness? Where do we stand and what are we learning? We have presenters who are going to speak to these issues, but the public chat box in which you all are writing is going to have questions pop up, and we'll ask you to throw in your 2 cents on this. What do you think we're learning? Where are you standing? What more do you want to know? The next question is that we want to connect is, what do you know from the research? We have researchers who are going to share with us what the research is and what they're learning. But what are you learning from your practical experience or from things that you're reading or that are happening in your community? The third one is what housing and service models exist that are really addressing the needs, particularly for people experiencing homelessness who have serious mental illness. So we're hoping that between the public chat box and some polling that we'll do throughout the next 2 days, that we'll be gathering information from the participants. Now to our first panelist, Nan Roman. Under Nan's stewardship, the National Alliance to End Homelessness has grown into a strong collaborative partner with federal agencies and officials advising and advocating and meeting the needs of people and working with communities. The research, convening, advocacy function that the Alliance does, they are a font of information. They are there for all of us who work in this field. They're open to listening to your questions, whether they have the answers or not. So this is like our central convening place. It's sort of the big tent. So whether you work in probation or criminal justice, mental health or behavioral health, whether you work in housing people or you're a case manager, you're an outreach worker, the National Alliance to End Homelessness is a space where you can get information, pose questions, and convene with people who are doing work similar to you. Nan has built this organization from an idea, a brilliant idea, but an event that used to gather 60 to 70 people in a small hotel room is now something that has so many thousands of people coming to an annual conference that they have a couple of conferences a year. So we're really glad Nan could spare time to be with us and to let us know what she's seeing from her perspective and work. So Nan, take it away.
Well, thank you so much, Marty. I'm so glad to be here. Thank you to SAMHSA for inviting me to participate in the virtual summit. Thanks also to Dr. Everett for her leadership, and appreciate, as always, the words of my good friend and the wisdom of Marty Fleetwood. Before I start, Marty told you a little bit about the Alliance, but I'll just also say that we're a nonprofit organization that works nationally. Our mission is to use data and research and input from the field to figure out what's working best to end homelessness. And then we work with Congress and the administration to get federal policy and funding that supports those solutions, and we work with communities to implement those solutions. So that's us. We all know that homelessness is a complicated problem, but most fundamentally it's caused by the interaction between how much money people have and how much housing costs. Over the last 20 years, renters' wages have increased by 5%, while rents have increased by 61%, according to the Joint Center for Housing Studies at Harvard. Poorer people are most affected by this imbalance. Of all the 3,000 counties in the United States, there are only 22 in which a full-time worker making minimum wage can afford a one-bedroom apartment. In fact, if that worker had a family and needed 2 bedrooms, they would have to hold not 1, not 2, but more than 3 full-time jobs to afford it. Nationally, for every 100 extremely low-income households, so poor households, there are only 37 affordable homes, according to the National Low-Income Housing Coalition. And of course, people with behavioral health and other disabilities feel this shortage most acutely because they are disproportionately poor, with mental health and substance abuse disorders both a cause and a result of their poverty. If people with disabilities are relying on their SSI to pay the rent, they are also out of luck. According to the Technical Assistance Collaborative, there is no state in the union in which a person or couple living on SSI could afford a decent, safe rental unit. And people with disabilities have another hurdle to getting housing: discrimination. There is evidence that people with disabilities are the group most likely to be discriminated against by landlords. This may be compounded if the person is also a member of a racial or ethnic group that is discriminated against. And all of that can be even further exacerbated by the fact that people with behavioral health disabilities are disproportionately and often unjustly involved with the criminal justice system, which creates further impediments to them obtaining rental housing. So the income-rents dilemma is even more vexing and impactful for people with disabilities, putting them at higher risk of homelessness. To end people's homelessness, we need to get them into homes, remembering that the vast majority of people who are extremely poor, even those who have mental illness, substance abuse disorders, and the like, are housed. It's not impossible by any stretch of the imagination. We need to get people back into homes and connected to the services they need to achieve well-being. So how are we doing on achieving that goal? There are 552,000 people homeless every night in the U.S. That is a lot of people, but despite the fact that rents have been going up and incomes have not been keeping the same pace, the number of people who are homeless has decreased. Between 2007 and 2018, the U.S. has reduced homelessness 15%. It has reduced homelessness among individuals 10%, reduced family homelessness 23%, reduced chronic homelessness 26%, unsheltered homelessness went down 24%, veteran homelessness went down 48%. Youth we don't have a good baseline data on, so we can't make the same assessment. During that same period, 2007 to 2018, the population went up 9%, rents increased more than incomes for poor people, and we had a recession. So all things being equal, the number of people who are homeless should have gone up, but it didn't go up, it went down. So how was that achieved? Well, I think there were several things that were involved. Certainly demographics may have had an impact on it. There was a significant increase in funding for and attention to ending homelessness among veterans during that period. Around 70,000 HUD-VASH permanent supportive housing units were added to the stock for homeless veterans, higher need homeless veterans. Hundreds of millions of dollars were invested in rapid rehousing, and there's been tremendous political will to end veteran homelessness, including the White House Mayor's Challenge to end veteran homelessness. As I mentioned, the result of all of that was to cut the number of homeless veterans by more than half. I might also note as an aside that the often touted success in reducing veteran homelessness and its use as a proof point that we could end homelessness for everyone is really down to two things. One, that we have the right tools in our toolbox to end it for everyone, which we do for veterans, as I mentioned, including rapid rehousing, permanent supportive housing, diversion, and of course the services that are delivered by the VA. And it's also down to the scale of the funding. On the veteran side, there's considerably higher per capita spending on each homeless veteran than on homeless people overall. So the right solutions and enough money are really what it takes to go to scale. Another factor in the decreasing overall numbers of homeless people is that, generally speaking, despite the fact that the problem has been getting smaller, Congress has been increasing funding for homeless assistance. There are several reasons for this, but an important one is the great work that has been done by the homelessness sector. Providers have been increasingly adopting effective and evidence-based approaches like housing first, trauma-informed care, and critical time intervention. There has been the move away from program-by-program approaches at the local level and toward systems approaches, which makes our work much more effective, efficient. And outcomes have improved. More people are returning to housing, and because the programs are effective, Congress has continued to increase investment. So that is the good news. Homelessness has been trending down since 2007 because of a clear set of successful strategies, improved effectiveness in the sector, and support from Congress. Unfortunately, there are also some less positive trends. The downward trend in homelessness seems to have stalled. The number of homeless people went up slightly in both 2017 and 2018, and I expect it will go up again and a bit more even this year when we get the 2019 numbers. Homelessness has not gone up in every continuum of care or every jurisdiction. In many places, the decreases have continued, so in your community the numbers might still be going down, but in 2017, a majority of communities, COCs, across the country had decreases, and now the majority of COCs have increases. Further, I think that there are some areas for which our strategies and approaches are not so clear, and sizable subpopulations are being left out. Unfortunately, this includes quite a few people with mental health and substance abuse illnesses. The area where we don't have the clearest vision about strategies, nor the dedication of resources, nor, it seems, really the will, is for individual homeless adults, other than those who are veterans or chronically homeless. Individuals get whatever is left over, basically, after everyone else has been helped. And it's a problem, not the least, because individuals are the biggest homeless subpopulation. There are 372,000 homeless individual adults. That's 2/3 of everyone who's homeless. About 250,000 of them are neither veterans nor chronically homeless. Individuals fall into groupings around age, gender, race, disability, status, and geography that can be useful when thinking about what we should be doing to help them. In terms of age, 10% of individuals are under 25, and about 1/3 are over 50. It's important to remember that homeless people become elderly at around 50. So we have younger and older people to consider for solutions. On gender, most individuals experiencing homelessness are male, but nearly 30% are female. In most places, there is little or no programming or protections for homeless women on their own. There are also people who are non-cisgender for whom we don't have good data, although we do know that they are underserved and can be especially vulnerable. On the racial groupings, the majority of homeless individuals identify as white, 54%. Whites are underrepresented in the homeless population. African American individuals are overrepresented at 35% of the homeless individual population, but only 13% of the general population. Native Americans, Alaska Natives, Native Hawaiians, and Hispanic and Latinx people are all also overrepresented. We must push back against the systems and racism that cause these minority groups to be disproportionately homeless, and we must be rigorous in examining our own systems and programs to make sure we are achieving equity. Of course, disability status is another grouping. As many as 44% of homeless individuals are disabled versus only 19% of the U.S. population. Some of this disability is the cause of homelessness, and some of it is the result. Finally, homeless individuals are not evenly distributed across the country, although it is a problem in every state. More than half of homeless individuals live in just 4 states, Texas, Florida, New York, and California. California alone has 30% of all homeless individuals and nearly half of all unsheltered people. It has about 12% of the U.S. population, so this is very disproportionate. Most of this information that I've just given you is from Homeless Management Information Systems, so it may be missing a lot of the nearly half of homeless individuals who are unsheltered. Ian DeYoung, who many of you may know of OrgCode, has very recently, very generously provided the Alliance, the USICH, and HUD with tens of thousands of records of unsheltered and sheltered people, and we had them analyzed by California Policy Lab. While this data is far from perfect, it's not a representative sample and the information is self-reported. It's the first large sample of information about unsheltered people, and it has given us some new insights into unsheltered homeless individuals. Unsheltered people are less likely to be younger or older than sheltered people. They're more likely to be around 45 to 54. They are slightly more likely than sheltered people to be male, but women are considerably worse off when they're unsheltered across a number of indicators, including health. Unsheltered people are quite a bit more likely than sheltered people to be white than any other racial or ethnic group. They are a lot more likely to be in the western part of the country, and they are a bit less likely to be in the Midwest or the Northeast. In terms of their homelessness trajectories, unsheltered people have been homeless a lot longer than sheltered people, with a median of nearly 1,000 days since they were last stably housed, compared to 240 days for sheltered people. Not surprisingly, they are a lot more likely to have been involved with police, jail, ambulances, and emergency rooms. Importantly for this conversation, they are much more likely to have a disability than sheltered people. They score twice as high on the VI-SPDAT Vulnerability Index. They are 10 times more likely than sheltered people to have serious chronic health issues, and twice as likely to have a physical disability. And about half of them also report that health issues caused their homelessness. So that poor health is not just resulting from being unsheltered, it's also causing people to become homeless. Unsheltered people are more likely to suffer from mental health and substance use problems than sheltered people. When asked, unsheltered people are 5 times more likely than sheltered people to say that drugs and alcohol limit their ability to be housed. Unsheltered people are 3 times more likely than sheltered people to say mental health affects their housing stability. And unsheltered people are 25 times more likely than sheltered people to be trimorbid. 75% of unsheltered women are trimorbid. Unsheltered homelessness is obviously an urgent problem, and it mainly affects individuals, and it's something that we really do need to solve immediately. Individuals overall do not need that much that's different from what other homeless subpopulations need. It's just that we haven't really established a system that provides them with those things. They need meaningful outreach to those who are unsheltered. They need diversion. They need decent, low-barrier, housing-focused shelter. They need help with self-resolution. They need rapid rehousing. Besides the veteran SSVF program, almost no rapid rehousing goes to individuals through the COC. They need permanent supportive housing. They need other housing, and they need services, including help getting a job, because very few of them are going to get any assistance paying the rent. Most places, the most individual homeless people get is a shelter bed, and many obviously don't even get that. These are some of the concerns we have about individuals and unsheltered people. There's a whole set of other concerns about the aging population, and Dr. Culhane is going to focus on that in a moment. Together, unsheltered homelessness and the aging of the population mean that homelessness is very significantly a health, including a behavioral health problem. The solution that's most often proposed for people who are homeless for longer periods of time and have behavioral health problems is permanent supportive housing, a permanent housing subsidy plus services. The homelessness system has created a significant amount of permanent supportive housing. We basically had almost none in the up until the late 90s. Today, there are 360,000 units provided through the HUD Continuum of Care program and the HUD VASH program. This was developed on the theory that PSH, permanent supportive housing, would end chronic homelessness. However, last year, a study was released by the National Academy of Sciences that raised some important questions that we need to explore with respect to permanent supportive housing. This was a consensus study report entitled Permanent Supportive Housing, Evaluating the Evidence for Improving Health Outcomes Among People Experiencing Chronic Homelessness. Basically, the study found that there was not sufficient evidence from solid research to determine how effective permanent supportive housing was in the long run for homeless people other than those with HIV/AIDS, where there was strong evidence. Similarly, there was not sufficient evidence to determine whether permanent supportive housing was cost effective. The report stated that there is good evidence that stable housing, which is, of course, a social determinant of health, has positive effects and outcomes, and that lack of housing, homelessness, has bad health outcomes. Lots of evidence on the impact of housing. But the data was not there to show that health, including behavioral health, improvement or cost savings were resulting from permanent supportive housing versus other interventions. And there was little robust evidence about which services really made a difference to outcomes, what kinds of services, the type, the intensity, the duration, or the frequency. So they couldn't state what worked best for whom. The report also says that they were not sure if PSH helps with either housing or health for people who are abusing alcohol and drugs. I do want to clarify, this is important, that the study is not saying that permanent supportive housing does not work. They are just saying that the evidence is not there to say whether it works or whether something else might, this is probably the main point, whether something else might work better or cheaper or just as well. That is, other than housing, they do say that housing works to improve people's well-being. To me, this indicates a couple of things with respect to people with behavioral health disorders and more generally to address housing and health needs of people who are homeless. One is that people need housing and that housing first is the best approach. And two, that they need services, but that we need to make sure that the services are evidence-based and integrated, and we are learning what type and duration of services need to be linked to housing and what does not need to be linked to housing. In closing, there are many economic and other factors driving homelessness. Having a behavioral health disability exacerbates most of them, putting this population at more risk. Despite the headwinds, the number of people experiencing homelessness has gone down since before the recession. This is because we do know what to do if we move to a coordinated system structure at the local level, if we integrate and properly target services, and if we provide people with housing using housing first approach, we will make progress. We have been applying this to some homeless subpopulations, but looking to the future, we need to do more of it for individual adults and especially people who are unsheltered. A great many of both suffer from behavioral health problems. We need to understand the housing and health needs of the aging population, which Dennis is going to address, and we need to do much more innovation in the affordable housing space. In many cities, the people we care about are not going to be able to afford a market rate apartment without a subsidy, which they're unlikely to get. We are going to have to do whatever we can to create more affordable housing, including not just trying to build our way out of the situation, but doing systematic shared housing schemes, single-room occupancy housing, boarding houses, dormitory housing, accessory dwellings, and other less expensive forms of housing. Ensuring that people with behavioral health problems have housing will end their homelessness, enhance their ability to get the services they need, and improve their health outcomes and well-being. In a country such as ours, No one who is ill or disabled should live on the streets or in a shelter. We know what to do, and we should do it. Thank you so much.
Thank you, Nan. That was fabulous. Excellent. Really good information. I hope everybody was able to capture what you were saying, because it was very rich and full of comments that answered some of the questions that are coming in. For those of you who are entering questions, we're going to respond to all of them after all three panelists have spoken this morning. So this lovely technology manages to keep track of all the questions. We don't have to worry about losing them or having them be untimely. So keep putting them in, and we'll keep working through how to get them all asked at the end of the presentations. So it's really amazing to hear what's working, and that we can actually make an impact and see the numbers go down. Whether we can keep them down, whether we can get that to happen everywhere is a challenge, and we'll find out how that goes. But investing in housing and investing in treatment are clearly the direction we should be headed in. Functioning as systems so that you're not just single agencies and efforts, but working in a community altogether really is a very clear and strong point of how we should move forward. So our second presenter, Dennis Culhane, is an amazing person. Given all that he has accomplished, we should all hope to accomplish half this much. In the last 30-plus years, he's been one of the strongest researchers on homelessness that we have in the country, if not the world. And he has focused on not just homelessness and who people are and what the causes are, but also assisted housing policy. What kind of supports does it take, and what do they look like, and what can we afford, and what should we invest in? He has done studies that have explained the geography of homelessness, where people come from. He has done studies that have proved the cost-effectiveness of interventions like permanent supportive housing. If there is any practice that has moved us forward, it is something Dennis has touched with his research and his analysis. The thinking and the practice that showed the need for management information systems was right there with Dennis at the beginning, convening people and trying to get people to understand that collecting data was the way we were going to get where we needed to go. And in the absence of targeted homeless data, he figured out how to find data within the administrative systems of government where people already were being touched, whether that was healthcare or corrections. Dennis is now a professor and an investigator and the director of Actionable Intelligence for Social Policy at the University of Pennsylvania. So without further ado from me, Dennis, let us know what you're thinking now.
Okay, thank you, Marty. I appreciate that generous introduction. And thanks to Nan for that great overview. I thought in the little time I have that I would just go through a few recent studies that I've been doing along with some of my colleagues. Most recently, we've looked at this issue of the aging of the homeless population, which I'll describe. I've also worked with some folks looking at why we are seeing such significant increases in homelessness on the West Coast and a couple East Coast markets as well. So I'll show a little bit of data that seems to help explain that. And then I'll just touch on a few substance abuse and mental health issues, some research that I've done, but also some research that is ongoing and by others that I think is telling us some important trends. So the first thing that I want to talk about is this aging phenomenon. The census data, which is what I'm showing here, and this is single adult males because the census data on females combines families and singles, so you can't really look at the single adult phenomenon. But among the males, it's very, very clear and compelling here that there's a cohort phenomenon, what demographers call a cohort effect. Basically, since 1990, and certainly several years before that, the homelessness problem has been dominated by people who were born between 1955 and 1965. That would be the second half of the post-war baby boom era. Demographers actually predicted that there would be significant disadvantages, economic disadvantages for this group because they would be coming into a crowded labor market and a crowded housing market having been preceded by the first half of the baby boom population. And the baby boom was particularly significant. We've had baby booms and busts for 150 years, but the Great Depression in World War II created a very steep decline in births. And the result was a big rebound at the end of World War II. So what we're seeing here is that as time is going on, this cohort remains the dominant group in the adult homeless population, so that in 1990, the average of that group was 30 years of age. In 2000, that's 40 years of age, and in 2010, it's 50 years of age. In 2020, it's going to be 60 years of age. This is a group that previous research has found has a life expectancy of 64. So we're coming upon the old-aged and frail years for this population group, and it's going to have a very big impact on homeless assistance programs, as well as we're seeing it in the permanent supportive housing programs, because the same trend is holding there. We did some projections. A demographer at UCLA, Randall Kuhn, helped us to model some projections in 3 cities, Los Angeles, Boston, and New York, where we had the HMIS data, and the trend was consistent in showing that we're expecting to see a tripling in the population that's 65 and over who experiences homelessness. There are very few people who are 65 and older have historically experienced homelessness, but because of this tide that's moving through, we're going to see a very substantial increase in elderly homelessness. Here's just an example of what we can see in the over 65 population for New York City. The graph starts at 2011, so you can see relatively rare, proportionately 1,100 people in 2011, and that has grown to, it's basically more than doubled by 2019 to about 3,000 people. And we're expecting that to more than double again by 2030 to 7,000 people. So this is a rather significant increase, and this is, by the way, adjusting for the fact that we know the population is dying. And in fact, it's the number of people who are homeless in the cohort is actually shrinking over time. It's just that they're aging, and so their numbers among the elderly are going to grow rather significantly. One of the things that we did in this project was we matched up the HMIS data with the all-payer healthcare claims, with mental health and substance use treatment data, and nursing home data. And we looked at, well, let's say what historically is the use of these services for people who are over the age of 55. And so what we can imagine is coming ahead as those numbers are going up. And you can see that these are significant users of healthcare services. It increases with age. It does level out at around 70 years of age. But you can also see that inpatient care in particular is increasing, and nursing home utilization is increasing significantly. And that basically, in this case it's Los Angeles, the average person is using $20,000 a year in these healthcare services, as well as, by the way, the blue is shelter services, around $5,000 in shelter services. So these are significant costs and significantly higher than the general population. And these costs occur not just among people who are chronically homeless, but people who have short-term homelessness as well. So it's distinct from what we've seen in the past with adult homelessness. It's much more universally the case among the older homeless that they are high service users. We then broke these into different groups based on their acuity in terms of their health care and in terms of how extensive their homelessness history was. Here I think we're showing the New York data, and basically we broke it out into 4 groups. A small group that is that's the number 3, just 1.5%, who are really mostly using hospitals and nursing homes. The others are different variations of shelter users, so some who are extensive, some who are lower shelter users. But we did this because we wanted to then we wanted to look at the costs associated with those different groups So cluster 1, which is 85% of the population falls into that group, is the lower cost group, but even still, it's $18,000 average per person. And then what we did was we matched up, we came up with some housing models that are out there being used in the homeless assistance field, and we said if we applied a universal solution across the board, putting people into different kinds of housing programs, and we costed out those housing programs, what would that look like? And what would be the impact? So we used the literature, which roughly shows that you get about a 1/3 reduction in cost of service use when people who are homeless are placed into housing. We took those estimates and we came up with a more conservative and less conservative scenario. You don't see it in this graph, unfortunately, but the dark blue going to the lighter blue is going from the 55 to 60, 65 to 70, etc., going up with age. And then on the far right is the average housing intervention cost. It does assume that 1/3 of the population is self-resolving, which we do see in that 85% group, which is what we do see in observational studies and research, and that the other folks are either getting rapid rehousing, they're getting a shallow subsidy, or they're getting a permanent subsidy, or they're getting permanent supportive housing. And our paper, which you can find, goes into much greater detail on that. But basically, if you sort of averaged out these scenarios across these age groups, you would see that effectively the opportunity is to associated with the housing placement is to be effectively break even based on these averaging these scenarios. To try to put this in national perspective, we applied the population projections to the AHAR data, and it shows that nationally we're going to see an increase in the over 55 population, but in particular the over 65 population as we get out to 2030. And the over 65 group is going to grow from about 30,000 or so today to about 120,000 out in 2030. So this is going to be, if you think of a pretty significant problem on a national basis. And we estimated, again, averaging the costs from these 3 sites to the country, which has to be done with caution because the markets for healthcare costs are quite different around the country, but it looks like it could be about a $5 billion expenditure average each year. So a very significant amount of publicly funded services will be spent if we do nothing. And if we re-engineer those dollars towards housing solutions, we could spend the same or even possibly slightly less or possibly slightly more, but actually have a housing solution for everyone. So that is really an opportunity, I think, that we're hoping the field will work on. Okay, so switching to the high-cost housing markets issue, you know, as Nan mentioned, despite declines in homelessness overall around the country and in most places in the country, we have seen increases, significant increases in homelessness on the West Coast, in particular unsheltered homelessness. And so we decided to see how much of this could be potentially driven by these high housing prices that have been observed there and the increasing housing prices. So along with a colleague, Christopher Glynn, who's at the University of New Hampshire, and he was a postdoc at Zillow Research, we looked at what is the predicted rate of homelessness, and that's the bottom, the lower line here that is goes across the graph. That is, can you see my pointer when I do that? I hope. But anyway, that line, the lower line, not the one you're pointing to there, below that one, yes. That would be the expected rate of homelessness if you look at the housing affordability, percent of income spent around the rest of the country. But when you incorporate these high-cost housing markets, what you see is when the average person is spending more than 1/3 of their income on rent, you get this inflection where the rate of homelessness accelerates at a much greater speed. And and you can see that it spikes quite significantly. And this essentially is the phenomenon that's occurring in places like Seattle and San Francisco and Los Angeles, San Diego, and DC and New York. So one of the conclusions that from this is that the places that are most vulnerable to these rising rents, even if you, unaffordability and poverty hold 15% of the U.S. population, so in these high-cost areas, but they account for 47% of the population that's experiencing homelessness. So there's a small set of jurisdictions that have only 15% of the poverty population, but almost half of the people who are experiencing homelessness. So it does certainly call for a geographically targeted strategy, or certainly a more aggressive strategy by geography. And that the affordability problem, just as a way, if you compare a high-cost market like Los Angeles to a more moderate cost market like Baltimore, that the increases in rents have an 8 times impact on the rate of homelessness as a result of this inflection. So we think this research is important because there's a lot of questions about why these we're seeing these increases, and this certainly seems like to be a major, if not, it is the major driver. I did want to just mention a few things about mental health and substance abuse. Along with some colleagues, I recently completed a study on suicidality and homelessness. I'll mention a little bit of those results. Talk a little bit about the opioid use disorder and how that's having some impacts. And then talk about the potential for a millennial cohort effect that we think is emerging. So this graph here is showing this is from the VA, the data is from the VA, and it is looking at people who were treated for suicidality through a suicide attempt or ideation around the onset of their homelessness. And the center line in the graph is the day that the person first showed up at a homeless service within the VA. And what you see is a very profound spike in people being hospitalized or visiting an emergency room for a suicide attempt or suicidal ideation just prior to their showing up in homeless services for the first time. And we conclude in the paper that it is likely that the distress and the crisis that is leading to the homeless experience, which could involve a severe economic disruption, it could include a family conflict or disruption, or it could include a significant health event, a significant increase or experience of substance use or mental health issues, and that those things are both contributing to homelessness but also contributing to suicidality. So, of course, the association here temporally is very strong. And I think we found when you look at both before and after the homelessness attempt, excuse me, now I'm going to switch to, let me just make sure I got this right. Yeah, so this is actually looking at people who have been treated for suicidality and now looking to see what's the rate of homelessness around that suicidality. And what we see is 23% of the people who have been treated for suicidality have a homelessness experience just after, and 17% before, going out to a year. But effectively, if you combine that, 30% of the people in the VA who are treated for suicidality have some concurrent homelessness. So almost a third of the people treated in the VA who have some kind of suicidality treatment are having some concurrent homelessness. And the previous slide I should have mentioned is if you tabulate that, you get around 10% of the people who become homeless attempt suicide around the onset of their homelessness. So anyway, the conclusion from that, I just want to say, is that homelessness should be considered a primary risk factor for suicidality, and suicide prevention should be part of any effort when people are initially coming in contact with the homelessness assistance system. We also see the big trend out there, of course, is the opiate problem, and it is having an impact on homelessness. There had been, nationally, we know that just in the last 20 years, roughly, heroin use has gone from being about 1/3% in prevalence in the population. It's increased fivefold by 2012 to 1.6%, and opiate use disorder went from 0.2% to 7.7%. So those are big increases, more than tripling. The VA has found that 18% of the people who experience homelessness have had a treatment for an opiate use disorder, and that 34% of the people with a treatment for an opiate use disorder have experienced homelessness. So a very high rate of co-occurrence. And literature from earlier years found that the opiate treatment rate among homeless people was less than half of that. In fact, there's Carol North and colleagues have had multiple time frames, 1984, 1990, and 2000, so before the opiate crisis, where they were measuring substance use disorders and substance use in the adult homeless population, and they found a steady 5 to 7% rate back at that time. It was higher among men than women. So a rate of 18%, of course, would be a rather significant departure from the trend between 84 and 2000. And in that period, cocaine-related disorders, the crack epidemic was having an impact, but that was the primary growth in substance use from 84 to 2000. So the opiate is the new growth problem. Okay, just another comment on the aging issues. One of the things that we're seeing in the data as well is that the growth in the over 55 population, which is associated with that second half of the baby boom cohort, but we also see growth in the under 35-year-old population, in particular under 30. This has been growing over time. There's pretty clear evidence, certainly from New York City and some in the AHAR, but the AHAR data are not really disaggregated enough for us to see it as clearly, but basically it's suggesting homelessness is now becoming a bimodal phenomenon. It's affecting old people and young people. And the question is this a millennial cohort effect, people born between 1983 and 2000? And in particular, the peak in that birth cohort was in 1990. So, we've heard a lot about concerns about youth homelessness around the country as people have seen lots more young people coming into homelessness. And the question that's really raised is, was the problem that was identified as youth homelessness really more appropriately a millennial homelessness? So yes, they were youth at one time, but they are aging, and we should expect to see youth homelessness decline, whereas young adult and middle-aged adult homelessness will increase. One of the other things, because there's a larger birth cohort, as I said, 1990 was the peak. It was the peak. You have also a population-related increase in severe mental illness onset, which is mostly in the 20s, people's 20s. So we hear all around the country, places where I visit, that they're seeing lots of young adults with first onset of severe mental illness, and that the inpatient treatment system just lacks the capacity to be dealing with this influx, and just has been caught unprepared for a very predictable increase in need for psychiatric emergency and inpatient services associated with the aging of this millennial population into the risk period for schizophrenia and major affective psychoses. So in summary, clearly we think these cohort effects are having a big impact on homelessness. Most significantly, it's driving this rapid aging in the adult homeless population. We think that it's a few high-cost housing markets and severe unaffordability problems that are driving increases in homelessness in about 10 cities around the country where it's growing so rapidly. Our research has found a temporal relationship between homelessness and suicidality. Opiate use disorders are clearly having a big impact in the homeless problem. It looks like it may well have tripled in terms of its proportion impact on the population over the last 15 years. And we do need more research on this millennial cohort effect, but it should certainly inform our programs and the policies that we're designing, that they should be developmentally sort of age appropriate and focused as much as possible, not just expanding mental health services for people who are having onset of severe mental disorders, but also creating more opportunities to get back into the labor market or get into the labor market for the first time for people who, particularly in the wake of the Great Recession, who came of age in that period and who've been showing up in the homelessness system significantly over the last 5 to 10 years. So thank you very much.
Thank you, Dennis. That was really awesome, as usual. Really excellent information and a great way to pull together a number of different studies to show what people need to focus on right now. Hopefully it also provided, for those of you listening, an explanation of what some of the things are that you're seeing or hearing about, so you can sort of connect for your own experience to what research is informing us about the broader picture. We have a bunch of questions, Dennis, so I hope you'll take a break, have some coffee, and listen to Kristen, and then be back with us to respond to all the questions that have been coming in. We're going to turn to our third plenary session presenter, Kristen Yavorski, and I'd like to introduce her by saying that, having worked with her in her home state, I can tell you this woman is a leader in the supportive housing movement. She's both been very active in developing units, managing units, and pulling together the intensive community services needed to make the permanent supportive housing actually work. She's done that in New York City as well as Virginia, where she is currently the director of the Office of Community Housing. She keeps track of data, she pays attention to the numbers and the outcomes, and really all the components, budgeting, staffing, contracting, all the elements of what it takes to actually operationalize the system statewide. Kristen has a lot of experience with that. A lot of your questions that have come in are things that she would know how to answer. So we're going to let Kristen do her presentation before we dive into questions. Kristen, take it away.
Thank you, Marty, and thank you to SAMHSA for the opportunity to speak to you today. So you've heard the national perspective and some more information about homelessness in specific communities across the country. I'm going to talk specifically about Virginia's experience implementing permanent supportive housing for adults with serious mental illness. First, I'm going to give you a little bit of context. Virginia is a state of about 8 million people. 133 cities and counties, ranging from higher density communities outside Washington, D.C. to rural Appalachia. Some of the issues that we're looking to address with permanent supportive housing include the state's over-reliance on institutional settings as compared to other states. We have some recent legislation that now requires our state hospitals, if somebody's involuntarily detained for psychiatric treatment, to accept an individual if there's no local hospital bed. And that's resulted in a real census crisis at our state hospitals. We have, on any given day, about 150 individuals who have extraordinary barriers to discharge. And that just means that they're ready for discharge into the community. Clinically, they don't need to be in the hospital anymore, but they're facing a challenge to leaving the hospital. And most commonly, that's no housing setting in the community. Virginia also has an imbalance of spending on the community versus hospital investment. We'll look more at that in just a minute. Like most states, we're challenged with homelessness. Individuals with serious mental illness are overrepresented among the homeless population. For us, that means about 1,000 individuals with serious mental illness are homeless on any given night. And we all know that homelessness is associated with a host of other problems. Virginia is also undergoing a large-scale mental health system reform, and specifically there's a legislative effort called the Joint Subcommittee Studying Mental Health Reform in the 21st Century. And in 2016, they formed a specific work group to look at housing, which has really driven a lot of what I'm going to talk about today. So here's just some more information about that imbalance in investment in the community versus state hospitals. On average, states spend about 23% of their budgets on institutional care. In Virginia, we spend about 46% of our budget on state psychiatric hospitals. And conversely, most states spend about 75% of their state budget on community-based care, and in Virginia, we spend just over half of our budget. Virginia's pretty well recognized for its efforts to end homelessness, and you can see from the slide the impact we've had on reducing homelessness among every subpopulation that we look at. We announced an end to veteran homelessness across the state in 2015, and dramatic reductions for folks experiencing substance use disorders, families, chronic homelessness, and as well among folks with serious mental illness. But you can see our impact for folks with SMI has not been as dramatic, and so we're looking at permanent supportive housing as a solution to really accelerate the impact on folks with serious mental illness. So my agency is a treatment and service providing organization, but we do recognize that housing is healthcare. There's a subset of folks who are homeless or unstably housed who are using institutional and crisis care, and even if we provide the best treatment interventions, they're not sufficient. We know that we need to address their housing needs to disrupt this cycle of institutional use and housing instability. So not only is homelessness, housing instability a humanitarian crisis, it's also very costly. So we know that individuals experiencing these cycles are costing these emergency and crisis systems a lot of money. So this legislative work group was charged with identifying housing models to promote solutions to these issues, and they pretty quickly settled on permanent supportive housing as the solution. They didn't spend much time producing studies or reports. They identified permanent supportive housing as the go-to solution based on their exploration of their research. So we know, we've heard repeatedly today, that PSH is an evidence-based practice. We have lots of research showing that it improves housing stability and reduces use of emergency department and inpatient care, as well as reducing jail stays. So this legislative work group asked my department to look at what was the need for permanent supportive housing for individuals with SMI. So we looked at the data that we had available for folks in jails, individuals in assisted living facilities, individuals served by our community services boards. There are public behavioral health providers across the state, and individuals who are homeless. And so using an approach that's used at other organizations, including CSH, we determined that we needed across these subpopulations about 5,000 units of PSH just to meet the crisis needs of these individuals. So this is the state investment in permanent supportive housing since fiscal year 2016. This investment was really driven by advocates and by legislators through this legislative work group. And we've been successful in securing investment in subsequent General Assembly sessions so that in the current fiscal year we have just over $17 million for PSH, which for us produces about 1,200 units. So what does our PSH look like? We use SAMHSA's evidence-based standards for permanent supportive housing. Our program is structured so that programs have high fidelity to those standards. We ask programs to deeply target so that individuals who are being discharged from state hospitals, individuals who are chronically homeless, those who are in supervised residential settings, and individuals who are cycling through all of these settings are targeted for our PSH intervention. We use a scattered site model. Our funds are used primarily by the local PSH programs for long-term rental assistance, so that's structured very much like the HUD programs that you're used to. People pay about 30% of their income to rent. Our state subsidy funds pay the balance up to the fair market rent. We use a housing first approach so that individuals are prioritized according to their need, and that we will rehouse people if they lose their housing as well. We're also structured to be very low barrier, so our funding has no criminal background restrictions or requirements around legal presence, for example. Our funding also pays for staffing in the local programs to provide housing stabilization services, often called pre-tenancy and tenancy supports. So those are the housing-focused services that enable people to successfully secure housing and then help them resolve any issues that come up while they're housed that might jeopardize their housing. We fund the staff time to administer the rental assistance. We fund a range of one-time costs to help people get into housing and to stay in housing. And that funding currently goes to 15 community services boards and 1 nonprofit supportive housing provider. The primary supports, the supportive services, are not funded by this funding stream. So since we fund community services boards and they provide a range of services, they bring those services to the individual based on their assessed needs and preferences. So for some individuals, that's a sort of community treatment. Some folks might be getting case management, peer support, and psychiatry. Others might be getting skill building assistance. It just varies based on the individual. And the PSH staff is working to coordinate those services with the clinical teams, with the individual, and with their landlords. So we knew from the beginning that we needed to keep a close eye on outcomes so that we could demonstrate the effectiveness of this intervention. We collect client-level data from these programs that they submit to us monthly, and we also, as the State Mental Health Authority, collect data from the CSBs monthly as well. So we can see demographics for the folks we serve, about 60% male, 40% female. About half of the individuals served are African American, 45% white. Interestingly, you've heard a lot about demographics of folks experiencing homelessness. We see that kind of bimodal distribution of age among the individuals we serve as well. So we ask folks to deeply target and prioritize people with histories of homelessness and housing instability, and we can see from our data that they are doing that successfully. So in the 6 months before they move in, they're experiencing a range of issues related to their housing and serious mental illness. This Venn diagram that you see is actually built off our data. So you can see the overlap between the experiences of homelessness, being in a local hospital, being in a state hospital, and being in jail. And I think what's most impactful about this is that our system is still very siloed. So we think of individuals in state hospital just specific to that experience, but we're able to show that individuals who are in state hospital are they're not just there, they're experiencing all of these other problems, including homelessness, jail stays, and local hospital stays. So fortunately, they're successfully targeting folks with the need for this intervention, but they're also very successful once they get individuals in housing. So 93% of those housed have maintained stable housing. We also did data matching. So we have our own data that we collect, which is data from the CSBs, data from our PSH programs, and so we also match that with other data sets. So we have data from every local hospital across the state. We have data from all the jails across the state. And we did a match with our state Medicaid agency so that we could look at emergency room utilization. So what you see here is for a group of about 316 people who had been in PSH long enough, we examined their utilization of all of these settings before they moved in and after they moved in. So this is at 6 months for that group of 316. Their utilization of all of those sectors was reduced by about 27%. And so that there in the after category, you do see the orange is the cost of the PSH intervention. So altogether, that's about $9,000 in cost avoided. That's at the 6-month point for this group of 316 people. Oh, yeah, your slide looks a little wonky, but this is 1-year outcomes. So we had a smaller group of people who had been in housing for a full year so that we could look at utilization before and after. So for this group, the profile is a little bit different, but there's still a cost reduction even when you factor in the cost of the permanent supportive housing. And the reduction to those other sectors outside of the PSH is about 25%. So that's consistent with what Dr. Culhane was saying about what's seen nationally. This is a different way of looking at the 6-month outcomes where we can pull out the different sectors and see what the impact is by sector. So this is 6-month outcomes where you see 30% reduction in local hospital utilization, a 96% reduction in state hospital utilization, and reductions in emergency room, jail, and community services board cost at 6 months. Again, I said 1-year outcomes looked a little bit different, so still a reduction in local inpatient stays of about 7%, but it has kind of inched back up as people who, when they were on the streets, weren't getting issues addressed. So we do see folks, and this is not uncommon in studies across the country, where for a while there is a little more utilization of inpatient care, but still an overall reduction. Our reduction in state hospital stays still at about 89%. And here we do see an increase in CSB costs. And that's about a 17% increase. And so we can look at that a little bit more closely. So we can see exactly what those changes are in CSB utilization, because CSBs provide a range of services from emergency and crisis care to residential services, outpatient services, and then the services that you find in supportive housing. So that includes case management, assertive community treatment, and again, the CSBs are providing those services as the support component of PSH. So when we look at CSB service utilization by service type, we're still seeing the kind of pattern that we would expect. So emergency and crisis utilization is decreasing, and their use of those community-based supports is increasing. This yellow category that you see that's called consumer monitoring here, very fitting for this session today. That's where services funded by a SAMHSA Collaborative Agreement to Benefit Homeless Individuals grant are coded, and that grant funds, again, the services in supportive housing. So we're pleased to see this pattern. This won't be too surprising to folks, but it helps us to make the public case for the PSH investment. So most of the costs that we examined are health and behavioral health costs paid for by health insurance. This profile is changing a little bit. Our state just expanded Medicaid in January, and so we are seeing increased enrollment in Medicaid, obviously. But just, this just lets folks know that it is those costs that you see, the health and behavioral health costs, are public costs. So permanent supportive housing and our DBHDS-funded permanent supportive housing is one component of what we're working on in the state to expand PSH. Other things that we're excited about on the horizon, we have requested of CMS to expand our Medicaid program to include pre-tenancy and tenancy supports, enabling Medicaid reimbursement for those services that we're currently paying for with state general funds. That waiver application also includes supported employment as a component. There's a larger scale behavioral health redesign going on. We're definitely looking at the way that those redesigned services can help better support people in housing. We're also doing a lot of work to leverage federal housing resources so that we're not overly relying on state-funded PSH. And we're working collaboratively with our other state agency partners, and we have an action plan that guides our work to increase permanent supportive housing using a range of strategies to do so. Thank you.
Thank you, Kristen. That was really an excellent way to understand one state's response and approach. Number of things you said have triggered questions from the audience. I hope you don't mind staying on the mic, because it sort of like trying to reconcile some of what you're doing with some of what, for example, Nan said, that the National Institute study showed, well, we can't prove permanent supportive housing is the best intervention. We can't prove it's the most cost-effective intervention. Well, maybe they can't prove those things, but you're showing us that your data shows that for your state, it's certainly more cost-effective than doing nothing, than sort of homelessness as usual. Do I have that right, or did you do any comparison with other ways to house people to see whether there are, cheaper, different, better ways?
Yeah.
What do you think?
We haven't done that yet, but it would be interesting for Nan to clarify. I think we have a lot of research and data that shows us what I said early in my presentation, which is PSH is absolutely effective in improving housing stability and in reducing emergency department and inpatient care. And there are also lots of cost analysis studies that don't show increases to after PSH is provided. There's a range of impact depending on the study you look at. But I think what Nan was talking about was we haven't seen where PSH consistently impacts mental health symptoms. So that's the next frontier is how can we be sure that not only are people stably housed and not going to the emergency department and hospital, but that their recovery outcomes are improved most effectively. But Nan can clarify if I got that right.
Nan, you have your mic on?
Yes.
Can you jump back in?
Can you hear me? Yes.
Yes.
I was just describing the study. The study was completed a year ago. They were looking pretty much, I think in that context, they look at randomized control studies. So there aren't a lot of those, and I think that's one of the issues that they were saying. It's not that it doesn't work, it's that we don't have the evidence that we need to prove that it works. There is data about costs, but it's also not saying if you did something differently that was less expensive, because permanent supportive housing is relatively expensive. If you detach the services from it, for example, or did a different set of services, it couldn't find any standardization in the services. So I actually think it was less about whether PSH works or is worth doing, and more about the fact that they didn't have the kind of research that they felt they needed to say that it was proven that it works. But certainly many places have, as you say, the cost data, and many places find that it does work and that it's effective. Importantly, they did say that the housing worked and that there was evidence from that. The housing, so sort of reinforcing what you said there at the end, the housing part of it definitely improves people's lives, keeps them housed, and improves their health. It's the services that I think are kind of all over the map, really, that I think we're having more trouble making an overall statement about.
Right. So Dennis, do you have any familiarity with the study? Because I know you've looked at this whole issue.
Yeah, Nan is right that this is a National Academy of Sciences panel, and for them the gold standard is a randomized controlled trial, and those are very few in number. And so the evidence, these pre-post studies are certainly some kind of evidence, but they're not considered as robust as a randomized controlled trial because there's selection biases potentially of who goes in, and there is sort of what they call melt over time. So the impacts tend to be biggest in the first couple of years, and then they trail off as the sort of regression to the mean phenomenon happens. So, so they're going to be very cautious in what they say. But in the real world is also not a randomized controlled trial. People aren't randomly placed into this housing. There are selection effects of who's going into the housing. So, I don't entirely agree with their conclusion, but I understand the standard that they're holding the literature to.
Right. Okay, that makes sense. So one of the other questions that came up has to do with housing. There's a number of questions actually about housing, and since we have a couple of sessions that are going to focus just on housing during the summit, I'm not going to go through all the questions, but one of them that came up really had to do with kind of should we place people out of housing after a period of time? Should we sort of look at the housing we provide through the homeless system as stabilizing people, not permanent as in forever, but should there be a period of time? A little bit like rapid rehousing, the way that works. Any comments on whether having people move on is a good idea, is even feasible? What do you guys think?
Well, I can say this. Oh, go ahead, Dennis.
I was going to say there is about 15% of the people do leave supported housing over a 2-year period, and over a 5-year period, it's like 65% remain, 35% have exited. So there is turnover, and most people who leave to a shared living arrangement with family, friends, or a partner. Only a small proportion of the exits are returns to homelessness or to incarceration. Of course, people die as well. But most of the departures are people who are moving on to other shared living arrangements.
And this is Nan. I was just going to say something similar. I think both from the Section 8 program overall, not just to people who are homeless, people don't stay on these subsidies forever. The majority of people don't. And I think setting arbitrary time limits on how long people are subsidized is not the best. I would say rapid rehousing, is a second best to a housing subsidy. If we could get housing subsidies for everyone, it'd be much better. this really has nothing to do with people trying or their being well or not well. It really just has to do with the market, that people who can't, earn at a higher rate can't afford the rents, not because of anything they're going to learn or improve their behavior or anything else. So I think arbitrary periods of time, not so good.
Good. Another question, actually a series of questions that came in that seem to be touching a frustration with how the system works, have to do with access, particularly for unsheltered people, access to mental health diagnosis and treatment. Any comments on that? We will be having sessions from outreach workers and some clinicians during the summit, but do any of you have anything to suggest or model that you know about or anything useful? How do we get people who are unsheltered access to mental health services and treatment?
Well, I would just say getting them housed would be a good first step. It's, I think, probably very difficult for people who are unsheltered to get access to any kind of assistance. Just physically difficult.
Right. And I think since we're on a SAMHSA conference, our federally funded, SAMHSA-funded PATH programs are an essential gap filler in communities. So those are outreach workers who specifically work with folks with serious mental illness to engage them where they are, hopefully to get them housed and connected to services. But we certainly know from those programs operating over a couple decades that it's challenging work and that our behavioral health systems aren't very accessible. So like most things, I think partnerships with those providers is really important, and depending on your role that could look differently, but helping to make sure that barriers to access are reduced and those providers understand the needs of that population is definitely important.
Excellent. I think another frustration that's come up in a question has to do with hospitals discharging people to the streets. Do you know if that's still happening in any widespread manner? And do you know of any interventions or policies that were put into place to stop it anywhere? Is there anything we could suggest on how to deal with that if somebody's seeing that in their community?
Well, I think the same answer about partnership is important to be sure. There are also respite centers, obviously, that are being created a lot of places, or recuperative care, so that people can exit into those kinds of facilities instead of onto the street. But I don't think that discharging people into shelter or onto the street has stopped most places.
Right. So with the increase in the number of unsheltered homeless in certain communities, is there anything we're learning about why it's not happening everywhere? Like, are there programs that are being successful in other communities, or is it just a function of housing cost, which is one of the things that's been mentioned? Do we have any?
You mean why unsheltered? Reasons? I'm sorry, Marty. Why unsheltered homeless rates are not? Why we don't see so many unsheltered people everywhere? Is that what you're asking? What's the difference between the places we see? Well, Dennis may have some insights on this, but I think that one thing is in some of the places where there's, for example, Los Angeles, where there's extraordinarily high, 75%, I think 74% of people who are homeless are unsheltered. They really never built up any shelter infrastructure, and now it's just very difficult to ramp up that capacity. San Diego, the same. So it's just kind of overwhelming the system, whereas other jurisdictions kind of kept up more with the shelter supply and don't have the same unsheltered problems. But I think there are other factors too.
Yeah, this is Dennis. We've looked a bit at this, and there's a very interesting historical explanation, which is that if you look at the nonprofit shelter and public sector relief programs back in 1929, 1930, which a researcher has done. 3 Worlds of Welfare is the name of her book, I believe. 3 Worlds of Relief. And what she basically argues is that in the Northeast and in the Midwest, where you had a lot of European immigration, there was a lot more sympathy, and unionization was going on at the same time, and you had industrialization of the workforce. There was wealth accumulation, there was a lot of philanthropy, and there was a sense of, white European Christians helping other white European Christians, to put it sort of simply. Whereas in the Deep South, it was still a very agricultural labor market. There was the legacy of slavery led to a very little interest in providing relief to poor people because it might disincentivize people, it was perceived, to work for very low wages in the agricultural sector. So the racism combined with the nature of the economy that wasn't generating the same kind of wealth didn't lead, there wasn't that infrastructure. And similarly, on the West Coast and in the Southwest, it was antipathy towards Mexicans and wanting people to come up and work in the agricultural industry, but not wanting them to stick around for, relief programs that in the off-season, wanting people to return. So this researcher argues that that historic pattern has led to, fast forward 50 years, there was much less capacity in the Southwest and in the South to provide poor relief when the homelessness problem emerged, whereas there was already people doing this work in the Northeast and the Midwest. And that had a particular impact when McKinney first came out, and it was a competitive grant program. So people who had programs and existed were far more able to get the grants. So until it became a formula program in 1994, those initial years continued to give a greater advantage to the Northeast and Midwest areas of the country. And so this pattern basically explains why there was much less infrastructure to build on, and that legacy has remained today with these unsheltered rates. And more than half of the people think, oh, people are unsheltered because it's warm in California or in Florida. But in fact, more than half of the effect of weather is wiped out by these differential relief patterns. And it really shows instead different kinds of labor markets historically.
Wow, amazing. There are, the last question I'm going to pose to our panel, there are a number of questions that have to do with sort of coordination and how to function as a system. So questions about, one of the things that you mentioned, Dennis, was opioid use disorder. So as a system, if we were able to decide where's the best intervention point to reduce homelessness, would it be for the people who go into an emergency room for that condition, or to people who end up in a treatment center, or to people who end up incarcerated? Like, how do we look at all those possible, I think of them as entry points into homelessness, or exit from a system of care into homelessness? Is there a way to look at them and decide where to start making an intervention, or do you need to start on all of them at the same time? Any thoughts, any of you?
I think all of those points are places of potential intervention, and critical time intervention, CTI, which is an evidence-based practice that was developed by researchers in New York years ago, and which has been shown to be effective and cost-effective by reducing reincarceration, reducing rehospitalization, and reducing homelessness. And that could be tailored to opioid use disorder as well, which is a structured, time-intensive, but decreasing in intensity, attempt to transition people out of these institutions and intensive treatment settings and into a community-based care system. And we certainly know that medically assisted therapy is the state-of-the-art for treating opioid use disorder. So one could envision a CTI initiative that was combined with MAT as a possible sort of joined-up intervention that might be particularly effective for this group.
Great. We are winding down our minutes, so unless Nan or Kristen have anything to jump on with that one, I'm going to move us into the closing seconds.
No, thank you, Marty.
Thank you. Thank all three of you, Dennis, Nan, and Kristen, for presenting today. Your information has been really what we needed to launch this summit into a deep and thoughtful state-of-the-art and also state-of-the-practice and where are we going direction. The tracks that are available for the next sessions, everybody has in your plenary program that you've been sent, and you have the instructions from Kristen about how to hit various links to get signed into the next session. All your questions on housing, employment, outreach, reentry, equity, all those questions, there is a session to cover that content. So sorry I didn't get to all of them, but as you can see, we are seconds away from running out of time. So thank you, participants. Hope you will stick with coming to the sessions that follow on this plenary and join us for the roundtable closing today, where we'll try to pull together themes that came up across all the different sessions and dive into the same ideas. How do we connect these dots? Where are we right now? Where do we need to be going? What's going to get in our way? And how are we going to get there together? So thank you, everyone. Look forward to talking to you in a couple of hours. This session can now end.